Yeah, good morning, students. I am Dr. Kumar Girendra, Professor and HOD Department of Respiratory Medicine, Index Medical College, Malvanchal University, Indore. Today, we will try to discuss or learn the topic difficult to treat asthma. Being you all a PG student, you must have learned the basic of asthma management. And you must have seen by now many patients of asthma in OPD and in emergency. And you must have also seen that some of the patients of asthma are easy to treat. But at the same time, you will find that some of the patients who are very difficult to treat and they don't settle on routine medicines. Okay. So, what do you mean by uncontrolled asthma? By definition, by uncontrolled asthma, it includes one or both of the following things. And what are those two things? One is that very poor symptom control, that is frequent symptoms or frequent use of reliever medicines, actively limited by asthma, and they have very frequent night awakening. And their exacerbation frequency is also more than 2 times in a year. And they require almost each time oral corticosteroids for settling their symptoms, for their serious exacerbations. And in fact, it may also require more than one hospitalization. Okay. So when you have these two types of conditions where the number of exacerbation is more than 2 per year and requiring oral corticosteroids, okay, and serious exacerbation which may be even more than once in a year, which require hospitalization, then this type of asthma is called uncontrolled asthma. In these type of patients, you have to first understand those patients and you have to modify your treatment. And what is difficult to treat asthma? Asthma that is uncontrolled despite of prescribing of medium or high dose of inhaled corticosteroids, that is ICS, with a second controller, usually a LABA, or with maintenance of OCS, that is your oral corticosteroids, or that requires high dose treatment to maintain good symptom control and reduce the risk of exacerbation. Okay. So once again, I will repeat that what is difficult to treat asthma? Asthma that is uncontrolled despite being prescribing of medium or high dose of inhaled corticosteroids, and with second controller, usually a long-acting bronchodilator, and even with a maintenance of oral corticosteroids. Yeah, and these high medicines are required to control their symptoms, and this reduces the risk of exacerbation. What is severe asthma? Severe asthma is a subset of difficult to treat asthma. It means asthma that is uncontrolled despite adherence with maximum optimized high dose ICS and LABA treatment, and management of contributory factors, or that worsens when high dose treatment is decreased. Okay, so in these type of patients, what you have to do is that you have to give high dose of ICS, LABA, and you have also to treat the other contributory factors. Contributory factors like, suppose if the patient is having hypothyroidism, you have to treat that also. Suppose if the patient is having any infective etiology like fever or any viral infection, So you have to treat that also. If you don't treat them, only just increasing the dose of ICS and lava will not settle the patient's symptoms. Okay, so how you will investigate and manage difficult to treat asthma? First of all, you have to confirm the diagnosis. And once your diagnosis is confirmed, then you have to go ahead with the treatment part. In difficult to treat asthma, which is defined if the patient has a persistent symptoms or exacerbation despite prescribing of medium or high dose of inhaled corticosteroids with another controller such as LAVA or maintenance of oral corticosteroids or requiring high dose of ICS LAVA treatment to maintain good symptoms control and prevent exacerbation. Okay. So what we have understood by now that if the patient is requiring high dose of ICS and LAVA for controlling his symptoms or for controlling his exacerbation, then you are confirmed that the patient is having difficult to treat asthma. Okay. So being a chest physician and suspecting a patient of difficult to treat asthma, what you have to do is first to perform spirometry. And the spirometry that you have to perform before and after bronchodilator activity. Sorry, you have to perform spirometry before and after giving bronchodilator. If initial bronchodilator responsiveness test is negative, that is less than 200 ml or less than 12% increase in FE1, we should consider repeating after withholding bronchodilators or when symptomatic. Okay. Once again, I will repeat. Suppose if initial bronchodilator responsiveness test is negative, and when do you call it negative? Suppose if the FBC, if the FEV1 is less than 200 ml or is less than 12% increase in FEV1 post bronchodilator, then we should consider repeating after withholding bronchodilators or when the patient is symptomatic. If a spirometry is normal or is not available, we should provide the patient with a peak flow meter and a diary for assessing variability. Okay, so what he has to do with the peak flow meter? He has to record his peak flow meter reading in the morning, in the evening, okay, after getting up and even in the evening. In fact, he has to repeat the peak flow meter reading after taking the bronchodilator or his medicines. Okay, you all got it? Okay, so performing the test, the first and the foremost test is your spirometry. If that is available, you have to do the PFT. Okay, and you have to see if the testing is negative, by which we have to see whether it's, the FEV1 is less than 200 ml or if there is no increase of more than 12%, then you have to consider this test as negative. And what you have to do in this type of patient, you should consider for repeating the test. And when you can repeat the test, that is your after withholding bronchodilators or when the patient is symptomatic. Okay. Suppose if you are, working in a place where the spirometry is not available, okay, or is normal, then in that case you have to just simply perform with a peak flow meter reading. What you have to do, you have to teach the patient how to perform the peak flow meter. You have to give him a diary and you have to tell him to record his morning and evening readings. You have to look for the reading on a regular basis. Okay, and while taking history, you have to look for the factors contributing to the symptoms and exacerbation. What you will find that in most of the time that the technique of inhaler technique utilization is not proper. You will find that in nearly 80% of the patients, they don't take the inhaler properly. For this, what you have to do, we have to tell the patient to take the inhaler in front of you and you have to see his technique, whether he is inhaling that medicines properly or not. Okay, if he is not taking the medicines properly, you cannot expect a good result from him. Suboptimal adherence, that is up to nearly 75% of asthma patient, you have to ask about the frequency of use of inhaler. Many of the time, they are not taking the medicines as frequently as advised and as in the dosage which has been advised to them. And most of the time, this happens because of their monetary problems. Not all, but many of the patients, okay, they are not very affording, and instead of utilizing those medicines, they prefer to keep that medicines for reserve. Means that they don't want to take the medicines when they are relatively better. They want to keep the medicines, reserve the medicines only and only for emergency use. Okay, so you have to tell them not to do these type of things. You have to tell them that they have to take the medicines properly and in the proper doses and at the proper time. Okay, you have to look for other comorbidities. That is, after a careful history and physical examination to identify whether symptoms are symptoms are typical of asthma or more likely due to an alternative diagnosis or comorbidity. Okay, while taking history, you have to differentiate between while taking history only, you have to differentiate yourself whether that breathlessness or dyspnea is related to COPD or that is related to obesity, or do you think that the problem is related to cardiac disease? Okay, suppose if the patient is having cough, okay, then you have to see whether the cough is because of some laryngeal obstruction, there is any vocal cord dysfunction, okay, if there is any post-nasal drip type of syndrome, if the patient is giving you a history of any gastroesophageal reflux disease type symptoms, or if the patient is on any antihypertensive medicines like ACE inhibitors, you have to ask for the history of bronchiectasis. So by asking all these history in detail, you have to rule out all these causes of wheezing. Okay. You have to also look for any tracheomalacia, tracheobronchomalacia type of feature if the patient is having. Okay. So if the patient is having all these type of features, until and unless you try rectifying these problems, only giving medicines for your asthma will not be sufficient for treating the symptoms. Okay, now we will discuss on something called modifiable risk factor and triggers. What are these modifiable risk factors and triggers? Suppose if the patient is having the habit of smoking, or if there is any environmental tobacco exposure at home, or if there is obvious allergen, indoor or outdoor pollution, okay, any noxious chemical medications, you have to look for all these things, and wherever possible, you have to encourage them to leave all those triggering factors, things which are responsible for his poor control of asthma. In fact, you will find that many of the patients who are unknowingly taking beta blockers, and when your NSAID, that is your non-steroidal anti-inflammatory drugs, that also increases your asthma problems. Okay, so if the patient is hypertensive and if the patient is asthmatic, you have to check for his antihypertensive medicines. And suppose if by mistake he is taking beta blocker which has been prescribed by some other colleague doctors, okay, you have to change those antihypertensive medicines. And suppose if he is having any medicines for arthritis or any other pain related management for which he is taking regular painkiller, so you have to tell them to avoid those regular use of painkiller. And as far as possible, if it's required also, you have to tell them that they have to take only safe painkillers, and they don't have to take NSAIDs absolutely at all. Okay, wherever possible, for allergens, you can check for sensitization using skin prick testing. Okay, then what you have to see, because of overuse of medication, that is regular and very frequent use of your short-acting SABAs, short-acting bronchodilator agonist, they causes beta receptor downregulation and reduction in response, leading in turn to greater use. What happens that when these type of patients are taking the medicines very frequently, in that case, the receptors get downregulated, and by taking the same dose of medicines, that does not give them proper relief. So what they have to do, they go on increasing the dose, and by increasing the dose further and further, that causes the beta receptor downregulation further and further. Okay. Overuse may also be habitual. Preferably, you should see that SABA's dispensing of more than 3 canister per year is associated with increased risk of emergency department visit or hospitalization, independent of severity. And dispensing more than 12 canister per year, that is one a month, is associated with substantially increased risk of death. See, so when the patient has come to you, you have to ask them how many inhalers they are using in a year. Suppose if the number is less, then you have to see whether it's 1, 2, or 3. Suppose if it's more than 3, then the chances of having the exacerbation which is more severe, which will require hospitalization, is very much high. Okay, so in those cases, you have to tell them that they should avoid triggering factor wherever possible. And suppose if the patient's use of Savas canister is more than 12 per year, that is almost more than 1 canister per month, okay, then these type of patients have even increased risk of death. Okay, and suppose if the patient is taking nebulized SABAs, then in fact that has got further more risk of death. So what we have seen that they should not overuse these medicines. They should use the medicine judiciously and as advised by the doctor. Okay, and what you should do when the patient's symptoms are controlled or relieved, you should try decreasing the dose of these medicines. It's not that once you have advised them, they have to take those medicines for months. Asthma is a disease where you have to increase or decrease your medicine usage as per your symptoms. As soon as your symptoms are controlled and they are controlled for a relatively sufficient amount of time, then you have to decrease the dose of medicines. And also you have to look whether the patient is having any anxiety problem, if the patient is having depression or any social and economic problems. So in case if you find all these type of problem, you have to consult them. If you think if that is of minor degree, which can be done by you, well and good. Or otherwise, you can also refer him to a specific doctor, a specialist doctor for these type of problems. Now we will discuss some common side effects of commonly used medicines. Systemic effects, particularly with frequent or continuous oral corticosteroids or long-term high dose of ICS, may contribute to poor quality of life. So again, we will see that we should use oral corticosteroids only when it's very desperate, or even if you are using ICS, okay, we should not use high dose of ICS for a very long time. These things should be used only when the problem is very severe in nature. And as soon as the severity of the symptoms are controlled, gradually these things should be tapered off. Okay. And one local side effects which is more commonly seen while using your inhaled steroid is dysphonia or thrush. Okay. This occurs because of high dose of potent ICS. Okay. And this is more common, especially if the inhaler technique is poor. Because whatever he is inhaling, all it's getting deposited in oral cavity and just throat only. Hardly, I mean, it's going inside the lung. Okay. And for this, what you have to tell them that after the use of inhalers, they have to do gargling. This gargling can be done even by just routine water, and this has to be done after each and every time using inhaler on a regular basis. Okay, so how you will optimize the management of patients? By optimizing is that first you have to again and again check the inhaler technique. Suppose if the patient's technique is not proper, he may take number of dosage of inhaler, but that will not be giving him the adequate result. Okay, so this inhaler technique should be checked by you on each and every visit of your patient. Okay, and whenever you find that the technique is not proper, you have to teach them the correct technique by physically demonstrating. Okay, and as far as possible, along with the medicines, you have to also consider for non-pharmacologic add-on therapy. And what are those non-pharmacologic add-on therapy? These are especially your smoking cessation, physical exercise, healthy diet, weight loss, mucus clearance strategy, influenza vaccination, breathing exercises, allergen avoidance. Okay, suppose if patient is having any of these things, you can tell them that other than your medicines, you have to avoid these things. If you are having a smoking habit, you have to leave that. You should do whatever physical exercise that is feasible for you, that you should do. You should have a healthy diet. Okay. If the patient is obese, he has tried to lose whatever weight which is possible for him. Okay. You have to teach them mucus clearance technique. Okay. They should get influenza vaccine regularly, annually. You have to teach them breathing exercises. And they should avoid allergen exposure as far as possible. Suppose if a person becomes breathless on going to a particular atmosphere, he should avoid going to that atmosphere as far as possible. Suppose if patient becomes breathless or gets wheezing after eating some particular medicines like ice creams, cold drinks. Okay. So as far as possible, you should avoid using those things. Okay. So once the patient's symptoms are controlled, you can ask your patient to visit the clinic at least every 3 to 6 months, even if they are asymptomatic. Because that will allow you to have, the long-term management plan of that patient for you. And when the patient comes to you, again you have to look for symptom control. Okay, exacerbations since your previous visit, any medication side effects, any inhaler technique and adherence. If possible, you can perform lung function and patient satisfaction and concern. Okay. Your patient should not be left unattended for a very long time. If possible, even if they are asymptomatic, you can tell your patient initially to have a follow-up at least approximately every 3 to 6 months. Okay, and you have to see and ask your patient like there were how many number of exacerbation during this period, whether the patient had any side effects or the patient has forgotten the inhaler technique. Okay, and preferably you should perform a lung function. Okay, by performing lung function, you can see the improvement of lung function from your previous reading if it's available. Okay, and you have also to see whether your patient is satisfied with your treatment pattern or not. Okay, other than these tests, if required, you can do the basic test like your CBC, CRP, IgG, IgM, IgE, fungal precipitant including Aspergillus, allergy testing for clinically relevant allergens by skin prick test or a specific IgE. Okay, not in all patients, but wherever if you feel, you can also do DLCO. Okay. Chest X-ray can be done on a routine basis, and if it's highly required, then only you can go for CT scan. If the patient is having oral corticosteroid use or high dose of ICS, then you can also get a bone density scan done. Okay, because you all know that of the risk of osteoporosis with maintenance of frequent OCS or long-term high dose of ICS. If blood eosinophil is more than 300 micro per liter, you can also look for non-asthma causes, including parasites, strongyloids, serology, and stool examination. Because parasitic infection may be the cause of the blood eosinophilia, and because OCS or biologic therapy in a patient with untreated parasitic infection could potentially lead to disseminated disease. Okay. Strongyloids infection is usually asymptomatic. Okay. So you have to look for eosinophils. If it's high, you have to look for other parasitic cause infection also, if it's available, if it's present or not. If there is evidence of hypereosinophilia, like blood eosinophil level is more than 1500, okay, you have to consider cases such as eosinophilic granulomatosis with polyangiitis. That is easy to know. Okay. Other testing which is not very frequently done or required is like ANCA, CT sinuses, etc. These tests are to be done only when if you are suspecting something. You have to assess the severe asthma phenotype. To assess the patient's inflammatory phenotype, is it type 2 high or low? What is type 2 inflammation? Type 2 inflammation is found in the majority of people with severe asthma. It is characterized by cytokines such as interleukin 4, IL-5, IL-13, which are often produced by the adaptive immune system on recognition of allergens. It may also be activated by viruses, bacteria, and irritants that stimulate the innate immune system via production of IL-33, IL-25, and thymic stromal lipoprotein by epithelial cell. Type 2 inflammation is often characterized by elevated eosinophils and may be accompanied by atopy. What do you mean by atopy? That is, generally they have familial inheritance. Okay. Repeating once again, majority of the severe asthma patients have type 2 inflammatory changes. Okay. Type 2 inflammation is found in the majority of the people with severe asthma. It is characterized by cytokines such as interleukin 4, interleukin 5, interleukin 13, which are often produced by adaptive immune system on the recognition of allergens. It may also be activated by viruses, bacteria, and irritants that stimulate the immune system via production of IL-33, IL-25, and thymic stromal lipoprotein 3 Again, repeating, type 2 inflammation is often characterized by elevated eosinophils, and most of the time it is accompanied by atopy. What you will see that in many patients with asthma which are having type 2 inflammation, they improve rapidly with ICS if that is taken regularly and correctly. This is classified as mild or moderate asthma. In severe asthma, type 2 inflammation may be relatively refractive to high dose of ICS. In mild to moderate asthma, they respond brilliantly to inhaled corticosteroids if it's taken regularly and correctly. But in severe asthma, this type 2 inflammation may be relatively refractory to high dose. Okay, so when you have to consider that the patient is having refractory or underlying type 2 inflammation, when you find that the patient is taking very high dose of ICS, or if you find that the patient is taking daily OCS. What is OCS? Then oral corticosteroids. If you find that the blood eosinophils level are more than 150, FeNO is more than 20 ppb, sputum eosinophil is more than 2%, and or asthma is clinically allergen driven. Okay, when you are doing this test, most of the time you will find that these biomarkers of type 2 inflammation, like your blood eosinophils, sputum eosinophils, and FeNO levels, most of the time they are suppressed by oral corticosteroids or because of the regular use of high dose of ICS. Okay, so these type of markers are not very informative when the patient is already on OCS or high dose of ICS. Okay, so if possible, these tests being costly also should be done only if the patient is not on OCS, because patient is already on OCS, and if you are doing this test, that will not solve the purpose, and you will not be any wiser. Okay. Consider non-biologic options if there is evidence of type 2 inflammation. For patients with elevated type 2 biomarkers, despite high dose ICS, consider non-biologic options first. Consider increasing the ICS dose for every 3 to 6 months and review again. For example, aspirin exacerbated respiratory disease, consider add-on leukotriene modifier. For allergen bronchopulmonary aspergillosis, consider to add on oral corticosteroids, or if possible, even if you can give antifungal agent also. For chronic rhinosinusitis or nasal polyposis, consider intensive intranasal corticosteroids, or in some patient even you can think of surgical advice. Okay, suppose if the patient is having severe DNS problem, large nasal polyp. Okay, even these intranasal corticosteroids may not help you on long term. So if the patient is of proper age, you can advise them for surgical excision also of polyps. Okay. In case if you find that patient is having atopic dermatitis, topical steroidal or non-steroidal therapy may be helpful for them. If available and affordable, consider an add-on type 2 targeted biologic for patients with exacerbation or poor symptoms control despite taking at least high dose of ICS LAVA and who have allergic or eosinophilic biomarker or need maintenance OCS. Okay, these you have to consider for those patients whose medicine requirement is very high. Okay. Next, to add on medicines, you can also add on anti-IgE for severe allergic asthma. Currently approved, that is your palivizumab for ages more than 6 years, given by subcutaneous injection every 2 to 4 weeks. May also be indicated for nasal polyposis and chronic spontaneous urticaria. Okay, so these newer medicines, palivizumab, but you have to give only for patients who are of more than 6 years of age, which has to be given by a subcutaneous injection, frequency of which is going to be your every 2 to 4 weeks, depending upon his symptoms. Okay, and this you can also consider initially for nasal polyposis and chronic spontaneous idiopathic urticaria. The mechanism of action is that binds to Fc part of free IgE, preventing binding of IgE to FcR1 receptors on mast cell, reducing free IgE and down-regulating your receptor expression. Okay, and what we have seen that the use of palivizumab, okay, this decreases the severity of allergic asthma by 44% in terms of exacerbation and overall improves the quality of life. In fact, this palivizumab can also be used in case of emergency, even in pregnancy patient, as by now till now there has been no increased risk of congenital malformation. Okay, in very rare case, the anaphylaxis reaction has been seen, but the frequency is less than 0.2%, which is very, very less. Okay, then some other add-on treatments are your anti-IL-5, anti-IL-5R for severe eosinophilic asthma. Okay, for ages more than 12 years, you can use your palivizumab, that is your anti-IL-5, 100 mg by subcutaneous injection every 4 weeks, or benralizumab, anti-IL-5, 30 mg by subcutaneous injection every 4 weeks for 3 doses, and then you can increase it to every 8 weeks. Okay, for ages more than 18 years, you can use also reslizumab, that is again your anti-IL-5, and this you can give 3 mg per kg by IV infusion every 4 weeks. Okay, for ages in between 6 to 11, you can use mepolizumab, anti-IL-5, 40 mg by subcut injection every 4 weeks. Mepolizumab may also be indicated for eosinophilic granulomatosis with polyangiitis, hypereosinophilic syndrome, and chronic sinusitis with nasal polyps. Mechanism: mepolizumab and risdiplam bind circulating IL-5. Generalizumab binds IL-5 receptor alpha subunit, leading to apoptosis, that is your cell death of eosinophils. Okay, but these medicines are not to be used on a regular basis for all patients. Okay, so the eligibility criteria is that the patient is having more than a specified number of severe exacerbation in the last year. Okay, and the blood eosinophils are more than 300, then only you have to consider for these type of higher medicines. Again repeating, anaphylaxis reaction are not very frequent, but they do occur. Outcome of these RCTs in severe asthma patients with exacerbation in the last year, anti-IL-5 and anti-IL led to 47 to 40% reduction in severe exacerbation. Okay, so when you are giving these medicines on the frequency as advised, that is most of the time every 3 to 4 weeks, then this definitely decreases the number of severe exacerbation in those type of patients. For ages more than 12 years, you can also use anti-IL-4R for severe eosinophilia. Okay, the medicine is dupilumab. Okay, this is anti-IL-4 receptor alpha, 200 mg or 300 mg given by subcutaneous injection every 2 weeks for severe eosinophilic type 2 asthma. For children 6 to 11 years with severe eosinophilic type 2 asthma, 200 mg by subcutaneous injection every 2 weeks, 100 mg if the weight is around 50 to 30 kg. This can also be indicated for treatment of moderate to severe atopic dermatitis and for chronic rhinosinusitis with nasal polyposis. Again, the mechanism is that it binds to the interleukin 4 receptor alpha, blocking both IL-4 and IL-13 signaling. Again, the eligibility criteria: these medicines should only be considered when the severity of exacerbation is more than a certain number in the last year, and the type 2 biomarkers are above a specified level. Example, blood eosinophils more than 300 and less than 1500, and FeNO should be more than 25 ppb. Again, what you see as outcome is that the number of exacerbation frequency is decreased significantly by around 56%. That is your severe exacerbation. Okay. You can also add anti-TSLP for severe asthma. That is your, but this you have to use only for patients who are more than 12 years of age and your one of the anti-TSLP is tazepilumab. Okay, the dose is 210 milligram by subcutaneous injection every 4 weeks. Anti-TSLP may also be considered in patients with no elevated T2 marker. Okay. In severe asthma patient with severe exacerbation in the last year, anti-TSLP led to 30 to 70% reduction in severe exacerbation and overall improved quality of life, lung function, and symptom control, irrespective of allergic status. Okay, so when you have started all these higher medicines, you have to review the response of these add-on biological therapy after 3 to 4 months. Okay, and after 3 to 6 months, you have to see especially symptom control, severity of exacerbation, comorbidities like nasal polyposis, atopic dermatitis, medications, that is your treatment intensity, including dose of OCS, side effects, affordability of the patients, and patient satisfaction. Patient satisfaction should be in terms of both his symptoms relief and his cost of treatment. So you cannot write a very costly treatment to a patient who is non-affordable. So you have to look for other cheaper mode of treatment for poor patients. If the patient has good response to type 2 targeted therapy, then you have to reevaluate the need of each asthma medication every 3 to 6 months. Okay, and you should not stop these medicines all of a sudden. Gradually and slowly, you have to taper these medicines. Yes, if your patient is taking oral corticosteroids for a long time, you should not stop them gradually. Otherwise, that would precipitate the symptoms. Instead of that, you should decrease the dose of OCS slowly, and if possible, you can add inhaled ICS. If patient is not taking OCS, but if the patient is only taking ICS, then also on his follow-up after his symptoms, as far as possible, you should try to reduce his medicine dose if his symptoms are controlled. But you should not stop them completely, all inhaled therapy. Okay, and the current consensus advice is to continue at least medium dose of ICS. And for biologic treatment, the current consensus advice is that generally for a patient with a good response, a trial of withdrawal of the biologic should not be considered until after at least 12 months of treatment. And only if asthma remains well controlled on medium dose of ICS, and for allergic asthma, there is no further exposure to a previous well-documented allergic trigger. Okay, again repeating, for patients who have improved on biologic treatment, their medicines should not be withdrawn abruptly. A trial of withdrawal of these biological medicines should only be considered after at least 12 months of treatment. and only if asthma remains well controlled on medium dose of ICS. And for asthma, there is no further exposure to a previous well-known allergic trigger. Okay, so we have to follow a collaborative optimization of patient care. Okay, so ongoing management of a patient with severe asthma involves a collaboration between the patient, the GP, the specialist, and other health professionals to optimize clinical outcomes and patient satisfaction. Okay, continue to review the patient every 3 to 6 months, including clinical asthma measures, symptoms control, exacerbation, lung function, comorbidities, the patient's risk factors for exacerbation, treatments, check inhaler technique and adherence, review need for add-on treatments, assess side effects, the patient's social and emotional needs. Again, repeating, when your patient is for follow-up, which will be coming after 3 to 6 months, you have to ask especially how his symptoms have been controlled, what has been the number of exacerbation, if possible, always do lung functions. Okay, look for the comorbidities. Also look for risk factors for exacerbation. Treatments, check inhaler technique again and again on each follow-up. Review the need for add-on treatment and always assess the common side effects and patient's social and emotional needs. Thank you for the patience.